So now, what we have here as the enzyme. This enzyme is supposed to break down what? What is acetylcholine esterase supposed to break down?
Acetylcholine.
Excellent. Supposed to break down acetylcholine, right? Now, what does it break down instead? It breaks down the drug, neostigmine. So now it's busy breaking down something else. So now what happens to acetylcholine? Does it get broken down?
Inhibit.
No. Okay, so
What will
acetylcholine
happen?
now. Exactly. Acetylcholine over here is not broken down. Acetylcholine is free, okay? And I have a drug that now is broken down by the enzyme. But guess what? This action of the enzyme on the drug is really, really slow. So it takes some time to be broken. So in this time, what happens to acetylcholine? Acetylcholine is not, it's like, you want to imagine it. It's like, um, for example, Tom and Jerry, So the acetylcholine esterase is Tom who wants to follow the mouse, is Jerry. Acetylcholine is Jerry, and now the mouse is free, and the enzyme, which is the cat, it says cat over here. So the enzyme breaks down the drug instead. Okay, so now it gets busy with something else, and now the enzyme or the acetylcholine in this case is totally free and does what it wants. And this is what we want. We want actually to increase acetylcholine on the receptors to increase the amount of the acetylcholine because we wanted to activate the receptors more. And this is one way of achieving it. Okay. And the final class, which is organophosphates. Now, guys, these drugs are very dangerous. Okay, why? Because they can bind to acetylcholine esterase, but they can bind to them almost irreversibly. So this process takes forever. Takes forever. So it takes like even it can block it forever. Okay, so now, acetylcholine will be high forever, and that can be very dangerous if they increase in so many places. Okay? So, acetylcholine will be very high in so many places. Okay, now, why is this dangerous? I'm going to talk about it in a bit. Okay, now let's start first with the uses. Okay, so did you understand the mechanism of action? So, these drugs, they do what? They inhibit the enzyme. Or they sacrifice themselves so that they can keep acetylcholine high in the synaptic cleft. All right? طيب. Now, what about the uses of these drugs? Okay? So these drugs, for example, we have here a non-covalent inhibitors, which is the first class. Okay, what about those? Those are called, the first one is called idrophonium. Idrophonium is a quaternary drug. Do you remember what it means to have a quaternary drug? A drug that is quaternary or positively charged? So, a drug, guys, that is positively charged, can it be absorbed?
Not absorbed fast. It cannot absorb.
Excellent stuff, excellent. So, guys, it's not absorbed. So, if I give it usually orally, can it go to the blood? No. If I give it orally or if I give it even as an injection, can it go to the brain and the central nervous system? Also, no. Why am I saying this? Because later on, we're going to have some drugs that can go to the central nervous system, and we need that effect. Why do we need it? Because we're going to treat some diseases inside the brain. Okay, you're going to see. Now, the first one is idrophonium. It's a quaternary drug, so it doesn't go to the central nervous system. It has a very rapid elimination, so it has a very short duration of action. Okay, how long? 10 minutes. Guys, is 10 minutes enough for me to treat a disease? Yani, can I use it for treatment?
No.
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 10 minutes? Never, right? So it's never enough. Okay, so what I need is, in this case, I only use it usually for diagnosis. Okay? Now, guys, I want you now to focus with me very much on this. Okay? This is a very, very important topic, and it's, yeah, I don't want you to get confused, so please focus with me, okay? All right, now let's go back over here. So this is used, we agreed that for 10 minutes, we cannot use it for treatment, so we use it for diagnosis, okay? What's the idea here? We have a case of a disease that is genetic. This disease is called myasthenia gravis, all right? What's the meaning of myasthenia gravis? It is a disease that usually happens in the person where what happens now? The skeletal muscles are weaker. Where? Usually in the face, usually sometimes can happen, usually can extend to the system, but it usually starts in the face. So what happens to the skeletal muscles? They are weak. What is the first symptom that the patient will feel? The skeletal muscles of the eye will be weak. So what happens to their eyelids? They will droop. They will drop. Can you see, guys? Is everyone listening? Yalla,
Yes,
let's do a wake-up test. Raise your hands.
Doctor, how is it take? Like, is it injection or as an oral?
Injection. We cannot give it orally. Yalla, guys, raise your hands to see who's awake. Yalla, we have a bunch of people who are awake. Not all of us, though. You let me call the other people. Ahmed, Taher, Ali Makki.
Yes.
Good morning.
Hi.
Morning, doctor.
Fatima.
I am already, pull my hands, but you didn't see me.
It didn't show here. Fatima
Yeah.
Baha, Haidar, Kazem. Where's Kazem? I didn't hear him today. Guys, wallahi, I missed our classes. Yeah, I know as much as you don't love classes, but wallahi, I missed our classes. I missed seeing you guys in campus. Muhammad Ali, Zahra Lu'ay, Zaid. I think they're sleeping.
I'm
They
here.
might be sleeping. You're awake?
Yeah, I'm here.
Okay. I'm glad that you are. Okay, guys, you can just unpress the button so that I know that you don't need anything. Okay, just to make sure that I'm not answering. Yeah, let's go back. Okay, so again, what is myasthenia gravis? It is a disease that usually happens where in the
Skeletal muscles.
excellent in the skeletal muscles. What happens to the skeletal muscles? They are
Get weaker.
Weak.
They are weak, right? So the first thing that the person will feel is drooping in their eyelids. Type, how do I know that the patient has this? Okay, so how do I diagnose it? I give it, we agree this is not absorbed, so I give it in the form of an injection. Where do we inject it? We inject it in the eye. All right. So once it's injected inside of the eye, what happens to the eye now? Now what happens? Let's think about the mechanism of action. The hydrophonium will do what to the choline esterase, the enzyme? It will block it. صح? It will block it. Okay. What happens to acetylcholine? It will
Will
increase or decrease.
increased.
Excellent.
Decrease.
Excellent. So it will go up, right? So it will increase. Why? Because we block the enzyme that breaks it down. Now we have more acetylcholine that are present at the level of the skeletal muscles. Does this tell us something? What's going to happen? What is the receptor at the skeletal
Contract.
muscles?
The muscarinic will be
مش muscarinic, no. Remember, there was a special receptor.
NN?
Excellent. Remember the NM? The nicotinic, the muscle
Yes.
type that is present, excellent. It's present at the level of the skeletal muscles. Those are the receptors that we want to activate to diagnose the disease. So what's going to happen now? More acetylcholine, they're going to activate the NM receptors. Now the eye is going to go back to normal. The muscles in the eye will go back to normal. Why? Because the problem is in those receptors that they are affected. When we have more acetylcholine, that means that they will somehow be more activated and they will go back to normal. Okay? And this is how we diagnose this disease. Okay, so what's going to happen? We have a patient coming in with their eye drooping. We inject idrophonium in their eyes. The eyes, for the duration of action of the drug, they're going to go back to normal. And after the drug is eliminated, they will droop back again. Okay, that's it. Then we know what happens. Then we know that this patient has myasthenia gravis. This is how we diagnose it. It's as simple. Okay? Now, I want to treat the disease. Is this disease treatable? Well, I have a bunch of drugs that I give. Not all of them are in this lecture because this is an autoimmune disease. So I have to do something with the immunity. So this is something that we're not going to take now in this semester. Okay, so we give some drugs that can modulate immunity. We give some steroids, cortisone. We give a bunch of drugs. But one of the drugs that we give is a class that also can activate the muscles, but it not only lasts for 10 minutes, it lasts for longer durations. And this is why we give, I'm going to jump just a little bit, we're going to give the second class, which is the reversible carbamate. Okay, so remember this. Okay, so we use the 10 minutes drug for diagnosis, and we use the longer acting drug for treatment. Okay? Why? Because I don't want the patient to lose control over their muscles. I want to keep on activating the NM receptors. Is what I'm saying making sense? Okay, amazing, guys. Thank you so much for responding. There. Now, this is also tricky, distinguishing between a myasthenic crisis and a cholinergic crisis. Okay, I'm gonna have to use new slide. Okay, guys, now listen carefully, okay? There's something I want you to know. Okay, so when we talked about nicotinic receptors, okay, what were those receptors in nature? Let's go back. Those receptors in nature were, I don't know. There you go. So those are what? What type of receptors are they? Are they G protein coupled receptors? Are they ion channels? What are those?
It's ligand gated.
Excellent. So they're ligand gated ion channels. So let's go back here. Well, guys, we finished a lot from this lecture. This is very big. So nicotinic receptors are ligand gated ion channels. So they are ion channels. Okay, so they are simple openings, okay, that allow ions in. Okay. This is the first thing we want to know. What is some property of these channels? Usually if I have a channel, channels have something, okay? They do not like to work more than usual, okay? So they have this property. Yani, if we activate them, usually they like to be activated for only a few seconds, okay? Not more. Yani, if I have acetylcholine that is high for a long period of time, does the receptor really like this? Is it that is something acceptable? No.
No.
So no, it doesn't. So what does this ion channel do? So in this case, the ion channels will refuse to work and they will be inhibited. So guys, this is the first time we hear that if I give an agonist or I give acetylcholine specifically for a long time, what's gonna happen? The receptor is gonna work, or the ion channel is gonna work. The ion channel is shutting down. You understood this idea, this concept? So this is a new concept, guys. I have never mentioned that in case we have a drug that can activate an ion channel, it will block it. This is the first time I ever hear about this. Ion channels are very moody or have an attitude. They don't like to work for so long. If they are obliged to work for so long, they will eventually shut down. Okay? Type. What did we just say, guys, about myasthenia gravis? What did we say about myasthenia gravis? We said in order to treat it, what do I give for treatment? A drug that acts for?
Long time.
Exactly. Usually slightly longer than usual. Okay? But what does this mean? If I have to be very careful about the dose that I give. If I give a slightly higher dose, what's gonna happen now to the skeletal muscle or the receptor?
Will shut down?
It will shut down. Excellent. It will shut down. It doesn't like to work anymore. So guys, what's gonna happen to the skeletal muscle? Will it be working? Will it be contracting?
Will be paralyzed?
Yes. Excellent. So it will be paralyzed. So guys, high dose. So what's the problem with myasthenia gravis? The problem is that the muscles are weak or almost not moving. I give the drug in order to help the muscles move more. But I give, let's say, sometimes by mistake, I give a high dose. What happens now to the muscle? It will also be
Will
weak.
stop working.
Exactly. So it will also be weak. So now imagine the disease causes weakness and the drug causes weakness. So both of them at the same time. Guys, is what I'm saying making sense?
One question.
Yes.
Yes. Yes, Basma.
What if the body built a tolerance against the drug and the patient needs a higher dose?
Yeah, in that case, that's gonna be okay because there is a need. But let's say I give a higher dose than needed, this is where the problem is gonna begin. Okay? All right, guys, let me now bring you back to this. So, guys, if we have myasthenia gravis, what happens to the muscle? It will be weak. And if I have a patient with myasthenia gravis and I give him a drug with an overdose, what's gonna happen to the muscle? It's also gonna be weak. So what do we call this? We call it a cholinergic crisis. So this phenomenon over here, when I give the drug, and this is called a cholinergic crisis. Okay, so how do I know? Both of them have weak muscles. Both of them, the patient will look exactly the same. But I need to fix this. So guys, how do I fix the cholinergic crisis when I give a higher dose and the patient starts becoming weak? How do I fix it?
Give another drug with reverse acting?
No. Let's talk about the same drug. What do I do to the dose?
Lower it?
I just lower it,
Decrease the
100%.
dose?
Thank you, Bas. Exactly. I lower it. I give a lower dose. So I need to decrease the dose. Tabai, let me give you another scenario. The patient comes into the clinic, okay, and he also has myasthenia gravis. I started with a drug, but let's say the drug is not enough, so the dose that I gave was too low. What's going to happen to the patient, to the muscles? They're also going to remain weak as well, the same thing. But what do I do in case the patient has a lower dose than usual? What do I need to do for the dose? I need to
Increase the dose?
increase it. So guys, now I have a problem. The patient with the myasthenia gravis who I started the drug on still has weak muscle. So it can be two things. It's either that I gave him a low dose and I need to increase the dose slightly, or I have given him a very high dose that was dangerous to them and it led to the ion channels to stop working and I need to bring the dose down. So we have two scenarios in this case. Both of them are opposite. So what do I do to distinguish between those two? I give hydrophonium. Same thing. I give hydrophonium in their eyes. If the hydrophonium was able to fix their weakness, this means this is the first case. So what do I do for the dose? I increase it. But if I give hydrophonium and it does not do anything because there's already a very high dose, then what do I do for the dose? I decrease it. I know this is the case where I need to decrease the dose. I don't know if what I said makes sense. Please let me know if I need to repeat it. It's a little bit complicated.
Can you
I know.
repeat it? Which
I will
one is
definitely.
like lower and which one is higher dose? How to distinguish?
Yes, yes, that's 100%. So now let me just say things again. Did you understand the idea if I give a drug that is an agonist for the NM receptors only in specific, the ion channels? If the NM or NM, I mean, in the ion channels in specific, if I give a drug, okay, that can activate the NM receptors for so long, what's going to happen to them? They're going to get what? Blocked.
Shut
صح?
down.
Then they were shut down. Exactly. They were not going to be working anymore. So let's say you have a patient who has myasthenia gravis. He came to, let's say he went to the physician, he prescribed the drug that we're going to take, the drug that is slightly longer acting for treatment in order to help the patient. He gave him a specific dose. That dose can be either too high or too low. If it's too low, what's going to happen to the muscles? Will they be strong again?
Remain weak.
They will
No.
remain weak. صح. And if I give a very high dose, what's going to happen to the ion channels?
They
Shut
become
down. 100%, they will shut down. What's going to happen to the muscles?
They
To
will
be
be
more
weak.
weak.
Also, they will be weak. So guys, it looks the same. If I give a high dose or a low dose, it looks the same. So I need a tool for me to distinguish between those. I need something to help me distinguish. What's that tool? It's an injection of hydrophonium. That injection of hydrophonium, I give it in the eye, where the muscle is weak. If the patient needed a more dose or if the dose was too low, the muscles are going to be fixed. Why? Because I gave him what was missing. But at the same time, if the drug was too high, even if I give more drug, hydrophonium, that's not going to fix the eye drooping. So guys, now I'm able to distinguish. So the final result is patient coming. How do I distinguish between those? I give hydrophonium. If the eye muscle got fixed, this is a low dose. I need to increase it. If I give hydrophonium and it doesn't do anything to the patient, then this is a cholinergic crisis where the dose was too high and I need to suggest for the patient to decrease the dose. Make sense? Well, if you understood this, you're champions.
Okay, but I have a question.
Go ahead, yes.
Okay, you said if we give a dose and it works, it means it's a low dose and we need to increase it, or just keep it like that. I
Yeah.
didn't.
Yeah, we need
Why
to
would
increase
we-
the drug.
Why? Would that make it more weak, or make it go back to being weak?
No, but because the problem is the patient needed a slightly higher dose. The dose, the correct dose is the sweet spot. Is a dose that is a dose that's not too high, not too low. Okay? So if the patient's muscles were still weak, okay, and we figured out with hydrophonium that the muscles were still weak, that means the patient needs a higher dose of the drug. That's it. That's as simple. So if a patient is, you have a patient, the patient is not responding to your drug, what do? You increase the dose.
Give them more.
Simple.
Yes.
You have to best. That's it. That's the whole idea. And it's simpler than the idea is simple, but because it's the first time you hear about these ideas, it's like slightly a problem. Okay. Do you have any questions?
Thank you.
I have a question.
Yes, go ahead.
If the receptors shut down, the patient will not be able to move again.
لا لأنه it's not complete blockade. It's not 100%. You don't give a dose that is totally irreversible and it's harsh. You give a dose that is enough to stimulate the skeletal muscles. Okay? And if it's a slightly higher dose, that's a slightly higher dose, not a very high dose. So it doesn't really do anything. Not to the point where the patient is at risk of something. Okay? Because this is why we don't use the ones that are very long acting because of this idea. Okay?
Okay.
All right. Okay, guys. Okay. One final idea. And this also requires some of your attention. So this talks about also the skeletal muscles. So guys, when we want to do a surgery to the patient, okay, so a physician wants to do a surgery, and what kind of drugs do we give for the patient? Can we afford to have the patient awake during surgery? Yani, if the surgery, let's say, is
No.
exactly. So let's say they're cutting down his abdomen. Do you think that's a good idea to have the patient awake and looking? أكيد لا, صح? It's يعني counterintuitive. So what we want is the patient to be unconscious. Okay? So for that case, we give some drugs. When they give anesthesia, and that anesthesia does what? It goes to the brain, and it does what? It causes the patient to be unconscious. صح? So it knocks the consciousness only. It doesn't do anything else.
Block
Nothing.
the pain sensation?
Yeah, pain sensation, yes. But does it relax the muscles?
Yes, it does.
Anesthesia does not. Remember this, guys. Anesthesia does not cause muscle relaxation. And when we want, for example, the patient, when the patient is not awake, what we want to assist in respiration. We want the patient's muscle to be relaxed. Why? Because when the physician or the surgeon is operating, he needs the muscles to be relaxed, not contracted. This will cause some problems. Imagine the patient having twitches in their muscles every now and then. That's a problem during surgery. Okay, so guys, what we want is the patient to be completely relaxed. Okay, so in that case, we give a drug that we're gonna take in next session. And that drug is called a neuromuscular blocker. What's a neuromuscular blocker? It is a drug that can inhibit the NM receptors. All right? Good so far? Okay, good so far. So this is what we do during surgery. What we do during surgery is I give anesthesia, and that's not enough. I need to also give a drug that will help the patient be completely relaxed. That's very good. Now we're done with the surgery. I need to do what to the patient? Imagine what's gonna happen if the anesthesia goes away and the patient wakes up and he's still paralyzed. Okay, so guys, remember, I gave two things. One thing causes the unconsciousness of the patient. The other thing causes the patient to be completely relaxed. So when I'm done with the surgery, the first thing I want to do, I want to bring the muscles back to their own normal function before the patient wakes up. The last thing I want to do is having the patient wake up and their muscles completely paralyzed and they cannot move them. Okay? So how do I bring the muscles back to normal? I activate the NM receptors. How do I activate the NM receptors? Very shortly, I give adrophonium.
By androphonium, quaternary drug يعني?
Yes, exactly. I give the drug. When I give adrophonium, what's going to happen to the patient? Now the patient is going to, muscles will go back to normal. Okay? And whenever we block acetylcholine esterase, acetylcholine will be higher in the receptors, and they're going to, by competition, they're gonna move away that blocker that I previously used. Okay, in that case, now what's gonna happen? The muscles are gonna be back to normal. And this is one other thing. Why do we use idrophonium? We use it to reverse the effects of the blockade that I used during anesthesia or during the surgery. Does this make sense? Amazing, you guys. Very good. Type. Now, one more thing. Okay. We also, guys, have a bunch of drugs that can go to the central nervous system. Okay? They can go, they are very lipophilic, and they can go to the central nervous system. And because they're lipid soluble, they slightly have a slightly longer duration of action. Okay? And because they can go to the central nervous system, I can use it to treat a very important disease. Guys, have you heard of Alzheimer's disease before?
Yes.
So what does Alzheimer mean? So what does the patient have when they have Alzheimer's?
They start forgetting.
Exactly. So they have memory loss. Okay. And what is our memory in the brain? Our memory is acetylcholine. Okay. So the problem with patients with Alzheimer's is that acetylcholine in the brain drops. So what I want is I want acetylcholine in the brain to be higher. Okay. So in that case, what do I do? Guys, can I give idrophonium for those patients? Patients with Alzheimer's?
It won't be
No.
absorbed.
It will not go to the central nervous system 100%, so I cannot use it. Okay, and also we agree that we do not use those for treatment because they're only 10 minutes. So we have another set of drugs that we use that are called donepezil and galantamine. Okay, and we have also tacrine, but tacrine is no longer used because it causes toxicity to the liver. It's hepatotoxic. Okay, but these drugs are really, really good because we can use them for Alzheimer's disease. They kind of increase acetylcholine in the brain, and that usually helps those patients to at least try and remember some of the things, okay? But Alzheimer's doesn't have a one drug that cures everything, okay? That the second class is reversible carbamate inhibitors, which is the second class. The second class, what is the properties? It is an intermediate acting. So is it long acting or a short acting? No, it's in the middle. Not very long acting, not very short acting. And we have a lot of clinical uses. Well, that we already talked about. So we have physostigmine and rivastigmine. Both drugs are lipophilic. So can they go to the brain?
Yes, true.
Yeah, can go to the brain. Amazing. So I can actually use them for Alzheimer's disease. But I have two other drugs that are called neostigmine and pyridostigmine that are positively charged. They can barely be absorbed. They cannot cross the blood-brain barrier. Can I use those for the Alzheimer's disease?
No.
I cannot. So what do I use them for? Those are the drugs that I use for myasthenia gravis. All right? Is it clear? Are you still following?
Yes, doctor.
Very good. Yeah. So this is it mainly for these two classes. How much do we have left? We have only one class left. Okay. Some of the drugs actually, guys, are used as insecticides. Okay, this is mean because look what we're doing to insects. We're paralyzing them. And that can actually affect what, guys? What's the problem with paralyzing? Affects what type of muscle specifically?
Skeletal muscles.
Yes, exactly. What type, skeletal muscles, but what organ are we worried about? Or what system are we worried about?
Breathing.
Yes, thank you so much, Radwan. Thank you. So those are, we're worried about the diaphragm and the intercostal muscles. So this is why sometimes we're very kind of scared when we give those drugs. Okay. But now we're left with the last class, which is the irreversible one, which are the organophosphate compounds. These organophosphate compounds, they are used as pesticides, insecticides or pesticides, okay? And some of them were actually used in certain wars. Imagine in wars, this is why because they usually stop the breathing of the person, and that can impair their function. They cannot move, they cannot walk, their breathing is impaired. That's the issue over here. That these drugs are very lipid soluble. So guys, even if someone wears a mask that prevents breathing of those agents, they can still go through the skin. Imagine. So they can just go through anything, dermal exposure. So these drugs are very, very dangerous. Okay, so you're not going to find a lot of them. You're gonna find a drug that's called ecothiopate. Ecothiopate is used to treat glaucoma. Do you remember glaucoma? What was it was?
The eye pressure.
Exactly, it's the pressure in the eyes. It's ocular hypertension or high pressure in the eye. So this is a drug, ecothiopate. It's a drug that can help with glaucoma, okay? And it has a very long duration of action. But is it like the first line treatment? Do we use this number one treatment? No, I don't. Okay, so we use this as a يعني last line treatment. If all the treatments fail, this is the last thing I use. Okay. Now the second drug is called malathion. What is malathion? It is a drug that is used for head lice. You know what's the meaning of head lice, you guys? Head lice, guys, is actually a condition that happens most commonly in children. Have you heard about the القمل in schools? Usually, sometimes this might happen in certain children. It's a type of parasite or insect that can happen. So, guys, did we ever talk about this? ما بعرف, I don't remember if we ever talked about head lice or not.
No.
Okay, let's just take it. Try to brainstorm. So, guys, is head lice a problem with hygiene? What do you think? What have you heard?
No, it's not.
Problem with what?
Is head lice a problem in hygiene? A problem in being
Yes,
clean?
it's actually, yes, it's a problem of hygiene.
Okay,
Like
no.
if we don't wash the hair, it's like it sticks in the hair.
No.
Okay, so this is actually what we have been told, okay, that it's a problem in hygiene. But guess what? If you have a child and you shower that child 5 times a day, and then they go to school and the person next to them has head lice, that lie's gonna jump on their hair. Simply, even if the child is that clean. Okay, so guys, it's an infection. Simply, it jumps from one head to the other. Okay, so even if you're very, very concerned about your child, and يعني, you just take care of the hygiene aspects, sometimes it's just gonna happen. So it's not always that. Okay, so just keep this in mind. It might happen to anyone's child if someone in their school, because why are we saying school? Because the children have to be sitting next to each other, which improves exposure, right? Which it enhances exposure, increases it. And the patient now or the child now is exposed to these kind of things. Okay, so how is it treated? It's treated with a drug that is used as a shampoo usually, okay, or topical on top of the head. This is malathion. Malathion is used to treat that kind of infection, and this is actually called pediculosis capitis. Okay, So it's safe in humans to be used because it's metabolized rapidly to inactive metabolites. Okay, and this was primarily used as a pesticide. Okay, but now this is used to treat head lice. All right. Do you have any questions? Very good. Okay, now let's talk about organophosphate poisoning. Okay, so what's the problem with organophosphate specifically? That they have a very long duration of action and they block usually all or they block acetylcholine esterase and they increase acetylcholine in all receptors. Okay, so they usually increase the neurotransmission everywhere. So what happens? Let's remember, guys, what happens usually to what happens when we activate the receptors, guys? What do you think happens? Let's talk about, for example, the eyes. What happens to the eyes?
Sweaty eyes, like tears and
Tears, lacrimation. صح. What happens to the secretions, guys?
increase.
Increased secretions, صح? Salivation, lacrimation. The eyes of the pupils of the eyes, I mean, will have meiosis. Okay. What else? Intestinal cramps. Smooth muscles will be contracted. Urinary bladder will be contracted. What happens now, guys, to the NN receptors?
It will be like weak and blockage.
Why? Why? But we're giving an
don't know.
agonist here. It's an agonist, yani it increases acetylcholine. What's gonna happen to the NN receptors?
Because the acetylcholine is very high, so it stops its blood.
Yes, exactly. So it blocks it. So now the skeletal muscles will be blocked, the person will be paralyzed, their breathing is going to be paralyzed, and that can lead to so many bad things. Respiratory depression is the thing that I'm very worried about. There you go, respiratory depression. Okay? This is what I'm worried about. So if I have a patient with organophosphate poisoning, I need to treat the patient. It's an emergency. I cannot wait. Okay, so I need to treat the patient before something happens. Okay, so there's something happens. This is called acetylcholine esterase aging, which is the enzyme that I'm blocking. Okay, sometimes when I give a drug that is an organophosphate, it usually is, sometimes it's reversible to a certain extent. But at some point, what's going to happen? It's going to change in structure because of simply just water. Okay, so water is going to make it change its structure. Okay, and what's the result after changes structure? It becomes totally irreversible and it's so stable now that it's so difficult to break. And when the enzyme reaches this stage, usually this is a stage that I want to avoid. I don't want. So guys, what's this phenomenon called? Aging. Why am I mentioning this? Because before aging happens, I can still rescue the enzyme. How can I rescue the enzyme? I give a drug that's called 2-PAM or pralidoxime. Okay, so what's this drug? This drug can help liberate the enzyme from the blocker. Okay, so this can help liberate them. But once aging has happened, is this okay to be given? No. This is why this is an emergency. I have to give the drug as soon as possible. And I also, of course, give acetylcholine receptor antagonists to stop the excessive acetylcholine from working in this case. All right? So bottom line, take-home message. Is aging something good or bad for the enzyme?
It is bad.
Very bad, exactly. I don't want it to happen. And usually I need to give a drug for the patient before it happens. What's this drug? This drug is called Tupam. Okay? Now that I have rescued the patient. Okay? Sometimes, you know, in wars, when there was some sort of risk of having these warfares, they usually gave pyridostigmine. Pyridostigmine is the drug that we previously talked about. Pyridostigmine will go and sit on the acetylcholine esterase, okay, and it will prevent the organophosphate from coming and binding. So it's like a protection mechanism to stop the patient from having these effects. Okay, so finally, what do I use acetylcholine esterase inhibitors? In case I have, for example, lost the tone of the intestines and the urinary bladder, I give neostigmine, okay, which is a drug that increases the tone of the muscles. Those are what? Skeletal muscles or smooth muscles?
Smooth muscles.
Smooth muscles, excellent. Smooth muscles. So this depends on muscarinic receptors, okay? Glaucoma, we agreed glaucoma. Why? Because what drug do we use? Ecophyphate, and it's the last line treatment. What are the side effects? Visual disturbances, of course. Myasthenia gravis, we talked about this so much. We have drugs for diagnosis like idrophonium, and we have drugs for treatment. Pyridostigmine, neostigmine, and we have the drug I haven't mentioned, which is called ambinonium. Okay, and we also have drugs that are used to treat Alzheimer's disease, like Tacrine, but no longer used because it does problems to the liver. Donepezil can be used, and it can be used in the form of sustained release, galantamine, and rivastigmine, which are lipid soluble because I need them to go to the brain to help the patient. All right. Do you have any questions, you guys?
No.
All clear, Yani?
Yes, doctor.
Okay, guys, I expect you next time to come knowing the lecture. All right? It's okay if you do not know the names of the drugs, yani in details, but I suggest you try to start memorizing them. But I want you to know the details of the mechanisms, the understanding of the lecture. Okay?
Okay, doctor.
All right, you guys. I'm glad to have you all again. And hopefully things will go back to go normal. I cannot tell you how the situation is here. It's somehow tough. Yani, and I always want you to keep me in your prayers and keep us in your prayers because the situation is really tough, you know. Okay?
Inshallah, you'll stay safe.
Thank you so much, Daniel.
Inshallah.
Yeah, guys, I think we're done for today. You're good to go. We finished early. And this section is ahead the other section.
Okay, doctor.
You're welcome,
Thank you,
guys. You're good
doctor.
to go if you wanna go. Bye.
Stay safe.